Graves' disease, treatment of Graves' disease. So, the hyperthyroidism of Graves' disease, how is that treated? It is treated either by reducing thyroid hormone synthesis using an anti-thyroid drug. So, we can give either an anti-thyroid drug or reducing the amount of thyroid tissue with radioiodine, iodine 131 treatment, or by thyroidectomy. So there are three ways by which we can treat hyperthyroidism of Graves' disease. That is by reducing thyroid hormone synthesis using an anti-thyroid drug, or reducing the amount of thyroid tissue. The tissue amount is reduced with radioiodine 131 treatment or by thyroidectomy. So in centers like Europe, Latin America and Japan, anti-thyroid drugs are the predominant therapy. Whereas in North America, radioiodine is the first line of treatment in North America. So anti-thyroid drugs are the prominent therapy in Europe, Latin America and Japan, whereas radioiodine is more often the first line of treatment in North America. So these differences reflect the fact that no single approach is optimal. So there is no single approach which is optimal, and patients may require multiple treatments to achieve remission. So there is no single approach which is optimal, and patients will require multiple treatments to achieve the remission in Graves' disease. So what are the main anti-thyroid drugs? The main anti-thyroid drugs are thionamides. The main anti-thyroid drugs are thionamides, propylthiouracil and carbimazole, and the active metabolite of the carbimazole is methimazole. So what are the main anti-thyroid drugs? The main anti-thyroid drugs are thionamides, propylthiouracil, carbimazole. Active metabolite of carbimazole is methimazole. So carbimazole is not available in the United States. So what all these drugs do? They all inhibit the function of TPO, that is thyroid peroxidase. So because of the inhibition of this TPO, so what is inhibited? TPO. So this reduces oxidation and organification of iodide. So these drugs inhibit the function of TPO. So because of the inhibition of the function of TPO, what happens? The oxidation and organification of iodide is reduced. And these drugs, they also reduce the thyroid antibody levels. So how they reduce thyroid antibody levels? The mechanism is unclear. And propylthiouracil, this inhibits deiodination of T4 to T3. Propylthiouracil, so this inhibits deiodination of T4 to T3, but this effect is of minor benefit except in the most severe thyrotoxicosis, and this is offset by the much shorter half-life of this drug. So this propylthiouracil has got a shorter half-life, that is 90 minutes compared to methimazole. So the half-life of methimazole is 6 hours. So this propylthiouracil also inhibits deiodination of T4 to T3, but this effect, so this is of minor benefit. And due to the hepatotoxicity of propylthiouracil, what is the main side effect? Hepatotoxicity. So because of this, FDA has limited its use to the first trimester of pregnancy. So because hepatotoxicity of propylthiouracil, FDA has limited its use to the first trimester of pregnancy, and for the treatment of the thyroid storm and patients with minor adverse reactions to methimazole. So FDA has limited its use to first trimester of pregnancy. In the treatment of various propylthiouracil use, because of hepatotoxicity, it is limited to first trimester of pregnancy. The treatment of thyroid storm and patients with minor adverse reactions to methimazole. So if propylthiouracil use, so monitoring of liver function test is recommended. So what we have to monitor? Liver function test. There are many variations of anti-thyroid drug regimens. Many variations. So the initial, if we take carbimazole or methimazole, so the initial dose is 10 to 20 mg every 8 or 12 hours, but once daily dosing is possible after euthyroidism is restored. So we start with 10 to 20 milligrams of carbimazole or methimazole every 8 hourly or 12 hourly. But once euthyroidism is restored, we can give once daily dosing. And propylthiouracil is given at a dose of 100 to 200 mg. This is in hundreds, 100 to 200 mg every 6 to 8 hours. So this also 6 to 8 hours. And divided doses are usually given throughout the course. So here throughout the course, divided doses are given. And lower doses of each drug may suffice in areas of low iodine intake. So wherever there is a low iodine intake, lower doses might suffice. So the starting dose of an antithyroid drug can be gradually reduced. Titration regimen as thyrotoxicosis improves. So if thyrotoxicosis is improving, so we can reduce the dose of antithyroid drugs. Less commonly, high doses may be given combined with levothyroxine supplementation, block replace regimen to avoid drug-induced hypothyroidism. We use this less commonly, that is high doses may be given combined with levothyroxine, because if we give high dose, what will happen? Hypothyroidism will occur. So we are blocking and we are replacing it with levothyroxine. So this is called as block replace regimen. So the titration regimen is preferred to minimize the dose of antithyroid drug and provide an index of treatment response. It should minimize the dose of antithyroid drug. So thyroid function test and clinical manifestations are reviewed 4 to 6 weeks after starting treatment. So we start the drug and we monitor every 4 to 6 weeks. And then the dose is titrated based on unbound T4 levels. So how we titrate the dose? Based on unbound T4 levels, that is free T4 levels. So most patients do not achieve euthyroidism until 6 to 8 weeks after treatment is initiated. So we have to wait till 6 to 8 weeks because most patients do not achieve euthyroidism until 6 to 8 weeks after treatment is initiated. And TSH levels, they often remain suppressed for several months and they do not provide a sensitive index of treatment response. So in hyperthyroidism, T4 levels have to be monitored. TSH levels, they remain suppressed for several months. They do not provide a sensitive index of treatment response. The usual maintenance dose of antithyroid drugs in the titration regimen are 2.5 to 10 mg of carbimazole or methimazole and 50 to 100 mg of propylthiouracil. What is the usual daily maintenance dose in the titration regimen? So this is 2.5 to 10 mg of carbimazole, or methimazole is 50 to 100 milligrams of propylthiouracil. In the block replace regimen, the initial dose of antithyroid drug is held constant and dose of LT4 is adjusted to maintain normal unbound T4 levels. When TSH suppression is alleviated, TSH levels can also be used to monitor therapy. And maximum remission rates, that is up to 30 to 60% in some populations, are achieved by 12 to 18 months for the titration regimen compared to 6 months for the block replace regimen. Remission rates, in the titration regimen, it takes 12 to 8 months for the remission, but whereas in block replace regimen, only 6 months. And remission rates are higher in patients in whom thyroid receptor antibody levels are no longer detected. Supposing if thyroid antibody levels are not detected, then the remission rate is high. So for unclear reasons, even remission rates, they appear to vary in different geographic regions. So remission rates depend on thyroid receptor antibody levels and also the titration regimen, as well as on the different geographic regions. Younger patients, males, smokers, patients with a history of allergy, severe hyperthyroidism or large goiter, they are most likely to relapse when treatment stops. but outcomes are difficult to predict. Supposing younger patients, male patients, smoker patients, patients who are having a history of allergy, severe hyperthyroidism, or patient who are having large goiters, what will happen? They are more likely to relapse when treatment is stopped, but outcomes are difficult to predict. All patients should be followed closely for relapse during the first year after treatment and at least annually thereafter. So what should be done? The all patients, no, they should be followed closely for relapse during the first year after treatment. So we have given treatments, or in the first year after treatment, they should be followed closely for relapse and annually thereafter. So what are the common minor side effects of anti-thyroid drugs? So these are rash, urticaria, fever and arthralgia. So these are seen in 1 to 5% of patients. The common minor side effects are rash, urticaria, fever and arthralgia, seen in 1 to 5%. So these side effects, they resolve spontaneously, or we can substitute it with an alternative anti-thyroid drug, and if there are any rashes, we can give antihistamine. And rare but major side effects include hepatitis. This is seen with propylthiouracil, and cholestasis, which is seen with methimazole and carbimazole, vasculitis, and most important is agranulocytosis, that is in less than 1%. So, but what are the major side effects? Hepatitis. So this is usually seen with propylthiouracil. Cholestasis is seen with methimazole and carbimazole, vasculitis, and most important is agranulocytosis. So this is seen in less than 1%. So it is essential that anti-thyroid drugs are stopped and not restarted if a patient develops major side effects. Supposing if a patient develops major side effects, what should be done? Anti-thyroid drugs are stopped and they are not restarted. So written instructions should be provided regarding symptoms of possible agranulocytosis. Supposing if a patient develops sore throat, fever, mouth ulcers along with agranulocytosis, so written instructions should be provided to stop treatment, and complete blood count should be done to confirm that there is no agranulocytosis. And it is not useful to monitor blood counts prospectively because the onset of agranulocytosis is idiosyncratic and abrupt. So how is the onset of agranulocytosis? It is idiosyncratic and abrupt. So it is not useful to monitor the blood counts prospectively. And propranolol, that is 20 to 40 mg every 6 hours, or a longer acting selective beta 1 receptor blockers such as atenolol, propranolol or atenolol. So this will help the adrenergic symptoms, especially in the early stages before anti-thyroid drugs take effect. If there are any adrenergic symptoms, so this will respond to propranolol 20 to 40 mg every 6 hours, or a longer acting selective beta 1 receptor blocker such as atenolol. Beta blockers are also useful in patients with thyrotoxic periodic paralysis pending correction of thyrotoxicosis. So these are also useful in thyrotoxic periodic paralysis. So in consultation with the cardiologist, anticoagulation should be considered in all patients with atrial fibrillation. There is often spontaneous reversion to sinus rhythm with control of hyperthyroidism, and long-term anticoagulation is not usually needed. So anticoagulation should be considered in patients with atrial fibrillation, and there is often spontaneous reversion to sinus rhythm with control of hyperthyroidism, and long-term anticoagulation is not usually needed, and decreased warfarin doses are required when patients are thyrotoxic, and if digoxin is used, increased doses are often needed in the thyrotoxic state. In the patient has got a thyrotoxic state, increased doses of digoxin is needed. In thyrotoxic state, warfarin doses, decreased warfarin doses are required. Warfarin doses decreased, but in thyrotoxic state, digoxin doses have to be increased. Digoxin to be increased. So this is about anti-thyroid drugs.